All right, so today we'll be going over Chapter 16, Respiratory Emergencies. As always, we're going to kick this off with a little bit of competencies. So as it says, medicine applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. All right, we'll be going over respiratory, as you can see there. In going over respiratory, we'll be hitting on some things like the anatomy, signs and symptoms, management of a respiratory emergency, and then we'll include emergencies that cover upper airway and lower airway. So emergencies from both upper and lower airway issues. All right, continuing on. We'll continue to do anatomy and physiology, pathophysiology, which is my favorite. Assessment, which we will definitely do an assessment at the end of the night. I have a pretty good little scenario. Y'all think about who wants to step up to the plate. Make sure you got your, maybe I don't need to hit the desk no more. But make sure that y'all step up to the plate, or whoever wants to step up to the plate, that you're prepared. You got your skill sheet ready to fire off. Somebody's gonna be successful tonight, just like we've had every other night. Nothing but success. All right, so some of the other stuff that we'll talk about the management of is epiglottitis, spontaneous pneumothorax, pulmonary edema, asthma, chronic obstructive pulmonary disease, otherwise known as COPD. We'll also talk about environmental and industrial exposure. We'll talk about toxic gas. We'll talk about pertussis, cystic fibrosis, pulmonary embolisms. We're going to talk about a bunch. As well as pneumonia and viral respiratory infections. Introduction. All right, so EMTs often encounter patients complaining of dyspnea. All right, so dyspnea. What is dyspnea? Can anybody pop up on the mic and tell me or describe to me what dyspnea is?
Shortness of breath in a patient.
Yep, difficulty breathing, shortness of breath. That's exactly what that is. All right, so that can be caused by many conditions, right? So dyspnea's cause, it can be difficult to determine depending on what it is. There's a lot that can go wrong with our respiratory system. So even without a definitive diagnosis, you may still be able to save a patient's life, right? So you see the basic issues that they're having, the signs and symptoms. So start working on fixing those signs and symptoms, those negative signs and symptoms. All right, so some of the stuff that we're going to talk about with the respiratory system, it's going to consist of all the structures that you see here: diaphragm, chest wall muscles. We got accessory muscles of breathing, so we'll talk about some of those. And when we'll talk about accessory muscle use, whenever someone's breathing, we'll talk about nerves from the brain and the spinal cord to those muscles as well. All right. In the upper airway, it consists of all the anatomic structures that you see here that's above the vocal cords. So above the vocal cords. Remember what the vocal cords are? If you were looking at down somebody's throat with a laryngoscope, those two white cords that you see just past the epiglottis, two white shiny cords let you know that's where home is for an ET tube, or a king, or something like that. All right, so what is above the vocal cords? So some things above the vocal cords are going to be your nose and your mouth, your jaw, your oral cavity, your pharynx, and then your larynx. Pharynx, larynx. And there's the pictures there, so I didn't have to point to myself and look silly. All right, pharynx, like where the nasal cavity is at. Larynx, a little further south. Epiglottis, you remember what the epiglottis is? It looks like a leaf. It can swell up. It can cause a lot of issues. But what does it do? Can anybody tell me what the epiglottis does? What does it do?
It keeps food from going down the windpipe when you're eating.
Yep. Keeps food, water, other foreign objects from going down past the vocal cords into the lungs. That's right. It also can get in the way whenever you're trying to intubate somebody. It can also become infected. It can become irritated, and you can end up with something that's called epiglottitis, and that can be very dangerous because once that swells up, guess what it blocks? The airway. You can also see the lower airways here, all the way down to the alveoli and the pulmonary capillaries. All right. So the principal function of the lungs is respiration. If you remember respiration, what we talked about. So respiration is the exchange of oxygen and carbon dioxide. That's the actual exchange of that O2 and CO2. All right, so as you know, air travels through the trachea into the lungs, and then from there it goes to the bronchi, the bronchioles, and the alveoli. All right, large, smaller, and then where the exchange actually takes place. All right, so the physiology of respiration. So there are two processes that occur during respiration, right? You have inspiration and expiration. All right, so oxygen is provided to the blood and carbon dioxide is removed from it. In healthy lungs, the exchange of gases takes place rapidly at the level of the alveoli. All right, so these figures here, they show a close-up of the exchange of oxygen and carbon dioxide within the alveoli, not to scale. Chapter 16, figure 2 and 3 is where you'll see those. If you learn all of this, then that'll kind of help you with your pathophysiology as we start to learn about different disease processes as well as injuries. Especially when we start talking about things like pneumonia, when we start talking about things like atelectasis, when we start talking about things like tension pneumothorax or simple pneumothorax or what have you, asthma, we'll talk about some of that too. Knowing that pathophysiology is going to greatly help you. And then knowing what's going to counteract those issues to help out this process is going to help you through your to get better field diagnosis as well. All right, so the alveoli lie against the pulmonary capillary vessels. Oxygen passes freely through tiny little passages in the alveolar wall into those capillaries through a process that's known as diffusion. Okay. It's then carried to the heart, which pumps the oxygen throughout the rest of the body. So carbon dioxide returns to the lungs and is exhaled out of the body. The brainstem, what it does is it senses the level of carbon dioxide in the arterial blood. all right, which is very important. So when we start talking about why do people breathe faster, why do people breathe slower, when we start talking about hypoxic drives, things like that, this is where that's coming from. When we start talking about how hangry the brain gets, and it tells the lungs, or it tells the heart, hey, I need you to beat faster. Hey, lungs, I need you to work harder. This is partly where that's coming from, or largely where that's coming from. If the level of carbon dioxide drops too low, the person automatically breathes at a slower rate and less deeply. So think about that. Okay? Think about what could cause that to be an issue. If the level of carbon dioxide rises above normal, the person breathes more rapidly and more deeply. All right, so think about on the other end of the spectrum how that works. Okay, start thinking about how that could cause issues, or what different types of disease processes could cause the carbon dioxide buildup. Or if we start talking about metabolisms. All right, pathophys. All right, so pathophysiology, the proper exchange of oxygen and carbon dioxide can be hindered by an abnormal or a pathologic condition in the anatomy of the airway. Also, disease processes, just like we were talking about, right? As well as traumatic conditions that can happen, and abnormalities in the pulmonary vessels can hinder the proper exchange. All right, so as an EMT, you got to be able to recognize the signs and symptoms of inadequate breathing and know what to do about it. All right, recognize the signs and symptoms of inadequate breathing. Carbon dioxide retention and hypoxic drive is something else you have to be able to recognize. All right, so your patients will sometimes have an elevated level of carbon dioxide in their arterial blood. So if levels remain elevated for a period of years, the respiratory center in the brain may not function properly. So the brain, what it does is for those number of years, it will gradually accommodate the high levels of carbon dioxide, and then it uses a backup system. All right, it kicks into the backup system. And what that does, it controls the breathing based on low levels of oxygen, known as what we call a hypoxic drive. So with these patients, you want to make sure that you use caution when administering oxygen to these patients. So right off the bat, the EMRs or anybody that studied, all right, what are some of our patient conditions that, let's name one big one patient condition that relies on a hypoxic drive a lot of times? That's right, COPD. Chronic obstructive pulmonary disease. So a lot of times you'll put an SpO2 monitor or a pulse oximetry on your COPD patients, and it will read a lower oxygen level. Sometimes they live in 88. You know, we're wanting 94 for our patients, right? Ideally. But for these patients, 88 is their normal. That's where they live at. Okay, so when we see that 88 and we're like, oh my goodness, I gotta pound you with oxygen. This guy's just sitting here smoking a cigarette and is like, nah, I'm all right. And then you go to give him oxygen after a while, and I do mean a long while, it will cause that hypoxic drive to kick in. So what happens is the oxygen will start, or the body will start getting all that oxygen in it. It'll get above that 94, 95, 96, 97, 98%. And the brain will say, hey, this isn't normal. We usually don't have this much oxygen here. Let's stop breathing so we can get back to our normal, because of the chronic condition that's been happening over years. So what'll happen at that point is that patient will stop breathing because their brain is saying they got plenty. They got what I need. I got what I need. Okay. And then that's when your hypoxic drive kicks in. You have trouble breathing, and that's a whole nother issue. And that's something that we can cause. Now, it takes a while to get there. So I'll just leave that up to you when we start talking about, how long can somebody be on oxygen? You have a COPD patient having trouble breathing. What should we do? We'll have discussions about that as well. So read into it as well. All right. Causes of dyspnea. So dyspnea can be caused by many medical problems, a whole bunch of medical problems. So altered mental status may be a sign that the brain is hypoxic. Patients often have difficulty breathing and or hypoxia with the following medical conditions, okay? So some of the stuff you see here is pulmonary edema, hay fever, pleural effusion. You have obstruction of the airway, hyperventilation syndrome, environmental or industrial exposures that you could have, toxic exposures or poison exposures. You have carbon monoxide poisoning. A lot of times that happens during storm season here. Up north, probably happens during winter season when a lot of snow knocks power out. So a lot of times when power gets knocked out, you'll see a lot of carbon monoxide issues. Also, drug overdose. Some others that you see here, you can see them all here. So you got to be aware that one or more of the following situations may exist in the dyspneic patient. All right, so gas exchange between the alveoli and the pulmonary circulation is obstructed by fluid in the lung, infection, or collapsed alveoli. So the alveoli are damaged and cannot transport gases at that time. They can't do it properly across their own walls. So at that point, the air passages are obstructed by muscle spasms. What can happen also is the air passages are obstructed by muscle spasms, mucus, or weakened floppy airway walls. All right. Blood flow to the lungs is obstructed by blood clots also. The pleural space is filled with air or excessive fluid, so the lungs can't properly expand. So the pleural space is the space between the ribs and the lungs themselves, like pneumothorax or hemothorax. We're talking about blood, or air and blood, which is hemopneumothorax. All right, so you can see here, this is a table that shows the signs and symptoms of inadequate breathing. Probably a good picture right there. Take you a snap of that. The selfie. Get you a selfie with it. All right. All right, so dyspnea is common. It's a common complaint in our patients with cardiopulmonary diseases. So congestive heart failure can cause the heart to pump inefficiently, and it deprives the body of oxygen, which causes a whole other set of issues there, partner. Also, severe pain can cause the patient to experience rapid shallow breathing without the presence of a primary pulmonary dysfunction. So rapid shallow breathing means that we're not fully expanding the lungs. We're not fully using all of the space that perfusion is happening, or that diffusion is happening. And so when we're not using all that space, we get this dead spacing issue that happens, and you can end up passing out. All right, so upper or lower airway infections. So like infectious diseases, they can cause dyspnea and may affect all the parts of the airway. Oxygenation is a problem of inadequate oxygenation delivery to the tissues. So when we start talking about disease processes, oxygenation may be a huge issue because of these disease processes. So the problem causing dyspnea is always some form of obstruction. All right, so these obstructions can be mucus and secretions obstructing airflow in major passages such as when you have a cold or when you have diphtheria. Swelling of the soft tissues in the upper airways, such as when you have epiglottitis or croup. You also have impaired exchange of gases in the alveoli, such as when we have pneumonia. All right, so we got to be diligent about the use of appropriate PPE when we're in contact with patients who have infectious diseases, because we don't want to end up with that junk ourselves, right? So wear the appropriate PPE. All right, so croup, our youngins. So inflammation and swelling of the pharynx, larynx, and trachea. Big description of croup. So typically, it's seen in children between the ages of 6 months and 3 years. Some of the hallmark signs of croup are going to be stridor and a seal bark cough. All right, we'll hear it. It's really terrible sounding. I get the same cough if I laugh too hard. Croup often responds to the administration of humidified oxygen. So if you got the humidified oxygen, the little bottle that you connect to your oxygen, that works great. Another thing is that if it's cool outside and I have a patient with croup, like child, I will ask to step out on the porch. Hey, can y'all come sit out on the porch so I can see what's going on? And a lot of times that helps their breathing a little bit. Another thing that I'll do is I'll go up and open the freezer, and then I'll do my assessment with the freezer open so that child can get that humidified air. Cool humidified air. All right, epiglottitis. So epiglottitis is inflammation of the epiglottis. It's usually as a result of a bacterial infection. So it's more predominant in children, but it can also happen to adults as well. Children are often found in the tripod position. So leaning forward, tripod position, hands on their knees, tripod positioning. And they'll also be drooling, right? A lot of times. So you got to treat them gently and try not to make them cry, because if they cry, it's just going to make it worse. It's going to get it more irritated, and it can become dangerous. So we want to make sure that we set these patients in a position of comfort and we provide high flow oxygen. Don't put anything in their mouths. So high flow oxygen would be like your through your simple mask or through your simple mask or your non-rebreather. All right. Generally, with these patients, I want to flow anywhere from 10 to 12 liters per minute. All right. RSV. I will screw up some words now. Respiratory syncytial. See, I'll screw it up. Virus. All right, RSV. So it's a common cause of illness in our young children. It causes an infection in the lungs and breathing passages, and it leads to bronchiolitis, and pneumonia is what it'll lead to. So it is highly contagious. So make sure you're wearing your proper PPE. You want to make sure also that you assess for signs of dehydration, and you want to treat the airway and breathing problems as appropriate. Speaking of bronchiolitis, let's talk about it. So viral illness, it's a viral illness that occurs due to RSV. And it usually affects newborns and toddlers. So the bronchioles become inflamed, swell, and fill with mucus. my messaging me? So with these patients, what we want to do is provide oxygen therapy and frequently reassess for signs of respiratory distress with these patients. They are sick patients. All right, moving on, talking about pneumonia. All right, so the general term refers to an infection of the lungs. All right, when we think of pneumonia, we think of fluid. When you're auscultating pneumonia patients, you can hear it in their lungs. It sounds like they're breathing through fluids. It almost sounds like what it was what's the plastic poppy paper that we use, the little air bubble paper? Come on now. Bubble wrap. So it almost sounds like bubble wrap, muffled bubble wrap popping when they breathe. So you listen for that. And sometimes you got to listen for it closely. You got to be listening very well for it to happen. Let's get you a good set of ears. So it's often a secondary infection that begins after an upper airway respiratory tract infection. Okay, so the bacterial pneumonia, it will come on quickly and it results in high fevers. So a little bit higher fevers with your bacterial pneumonia. Viral pneumonia presents more gradually and is less severe, usually no fever. So pneumonia especially affects people who are chronically and terminally ill, underlying conditions. So you want to assess the temperature to determine presence of fever with all your patients who are having a possible issue with this pneumonia here. And then you got to provide airway support and supplemental oxygen. So with pneumonia, a lot of times, if it's indicated, a CPAP works really well, especially if they have a lot of fluid in their lung, because it will push that fluid out of their lungs, helping them breathe better. All right, pertussis or whooping cough. Remember we said that's the whoop. All right, so whooping cough is pertussis. So it's an airborne bacterial infection that mostly affects children younger than 6 years of age. So the patients will be feverish and exhibit a whoop sound on inspiration after a coughing attack. So you'll hear the and that is the whoop. That almost choked me. All right. So it is highly contagious and it can be passed through droplet infection. They're coughing, hacking everywhere. So it may be good if you can to put a surgical mask over your patient. All right, so some things you want to watch for are signs of dehydration, because a lot of people don't drink, sore throats, what have you. Pay attention to that. And suction may be necessary for those patients as well. All right, influenza type A. So an animal respiratory disease that has mutated to infect humans. That's what influenza type A is. So it's transmitted via direct contact with basal secretions and aerosolized droplets from coughing. Now all of you have it. Thanks a lot. Symptoms include fever, cough, sore throat, muscle aches, headache, and fatigue. That's why they call it flu-like symptoms, because it's the flu. Now, influenza type A can lead to pneumonia and or dehydration. All right, we went over this already. COVID-19 or SARS-CoV-2. So it's a coronavirus that's similar to the one that causes the common cold. Okay, so it's a coronavirus that's similar to the one that causes the common cold. So preferentially, it affects the elderly patients living in close quarters with one another or those with weakened immune systems. So again, underlying conditions. Young and healthy individuals can also be infected by it. It's transmitted by aerosol droplets through airborne particle particles that are generated by sneezing or coughing and by direct contact. So some of the symptoms that are included are going to be high fever, cough, inspirational chest pain, vomiting and diarrhea, and anosmia. Anosmia. All right, so anosmia is just inability to smell. So anosmia, inability to smell. So respiratory deterioration can occur rapidly with COVID, as everybody in here probably knows because they've been dealing with it for the past couple years. All right, tuberculosis or TB. So TB is a bacterial infection that most commonly affects the lungs, but it can also be found in almost any other organ. It can remain inactive for years before producing any symptoms. So patients often complain of fever, coughing, fatigue, night sweats, and weight loss with tuberculosis. So there's a high prevalence in homeless people, prison inmates, nursing home residents, persons who abuse intravenous drugs or alcohol, and also those with HIV. If you do suspect your patient may have active TB, you need to wear at a minimum your gloves, eye protection, and an N95 respirator mask. At a minimum. All right, acute pulmonary edema. So the left side of the heart cannot remove blood from the lung as fast as the right side delivers it in acute pulmonary edema. So fluid then builds up within the alveoli and in the lung tissue. It usually results from congestive heart failure, CHF. The patient usually experiences dyspnea with rapid, shallow respirations. In some other severe cases, a frothy pink sputum forms at the nose and the mouth. So acute pulmonary edema, frothy pink sputum. Okay. So most of your patients have a long-standing history of chronic congestive heart failure that can be kept under control with medication. Not all patients with pulmonary edema have heart disease, though. All right, and there's a picture. This figure right here, it shows fluid filling the alveoli in pulmonary edema. All right, so what we're going to do now is it is 6:50 my time. It's whatever 50 your time. And I am going to go ahead and put us on break for 10 minutes. Hang with me. Going to be a wild ride. Not really. Just got to open up this. All right, 10 minutes. I will see y'all in 10. All right. Here we go. That's the picture. We're already seeing that picture. And we're going to move on to the next one. All right, so chronic obstructive pulmonary disease, or COPD. So chronic obstructive pulmonary disease. So it's a lung disease characterized by chronic obstruction of lung airflow that interferes with normal breathing, and it's not fully reversible. Chronic obstruction makes sense, right? Chronic obstructive pulmonary in the lungs disease. Boom, mind blown. All right, so umbrella term. This is an umbrella term that's used to describe a few lung diseases, including emphysema and chronic bronchitis. And use COPD because it's a chronic condition. So tobacco smoke is a bronchial irritant and can create chronic bronchitis, which is an ongoing irritation of the trachea and the bronchi. Easy peasy lemon squeezy, right? So with bronchitis, excessive mucus is constantly produced, obstructing small airways and alveoli. So the airways are weakened, and the protective cells and lung mechanisms that remove foreign particles are then destroyed. So chronic oxygenation problems can also lead to right heart failure, and it can also lead to fluid retention. So pneumonia develops easily in these patients. Repeated episodes of irritation and pneumonia cause scarring in the lung and some dilation of the obstructed alveoli, which then leads to COPD. Can I explain right heart failure? I can. So, cardiovascular will be next class. I don't know if you want me to get too far into it, or we can just do it next class when we talk about right heart failure. We'll stick to lung today, and then I'll talk about right heart failure tomorrow, and we'll talk about how it can cause backup of fluids and, edema and everything else when we start talking about congestive heart failure and how it attaches to that. We touched a little bit on it today when we talked about congestive heart failure, but I don't want to get too deep into it. All right. Continuing on with COPD. So emphysema is the most common type of COPD. Emphysema is the loss of elastic material in the lungs as a result of chronic stretching of the alveoli. Okay. Smoking can directly destroy the elasticity of lung tissue. I have family members with this that are in the later stages of it. So, I mean, it's a big issue. So most patients with COPD have elements of both chronic bronchitis and emphysema. They're always got that terrible cough. And phlegmy. They're really phlegmy. All right, so this picture right here, it shows damage to the alveoli characteristic of COPD. It's lost all its elasticity. It's like an old set of underwear. Sorry. All right. Wet lungs versus dry lungs. So patients with pulmonary edema it's caused most often by what we call congestive heart failure. They will often have wet lung sounds like bronchi and crackles. All right, crackles are the sounds that I was talking about. It sounds like the bubble wrap, the muffled bubble wrap, whenever they breathe. And patients with COPD will often have dry lung sounds or wheezes. All right, wheezes usually sounds upper, or I'm sorry, not upper, but it's lower. But if you've ever heard wheezes, I can't really do it that well. It's got like almost a whistling sound somewhat. So do not assume that all COPD patients have wheezing and that all congestive heart failure patients have crackles. Don't assume it. That would be a folly. So in these instances, just like it says here at the bottom, it's very good advice. Treat the patient, not the lung sound. Treat the patient. All right, asthma, hay fever, anaphylaxis. Asthma, hay fever, and anaphylaxis. It's all a result of an allergic reaction to an inhaled, ingested, or injected substance. So asthma. So an acute, what asthma is it is an acute spasm of the bronchioles associated with excessive mucus production and swelling of the mucus lining of the respiratory passages. So asthma, it affects ages, it affects all ages, but is most prevalent in children 5 to 17 years of age. It produces a characteristic wheezing as the patient attempts to exhale through partially obstructed airways. So an acute asthma attack may be caused by an allergic reaction to specific foods or some other types of allergens. Attacks can also be caused by severe emotional distress, exercise, and respiratory infections as well. Uh, in its most severe form, an allergic reaction can produce what we call anaphylaxis. Yep, you're absolutely right, Parker. If you see the chat, he's got a small snippet of a story there that he's explaining. It says, my mom has COPD and used O2 for 15 years. Eventually, it led to elevated CO2, which we talked about, right, in the blood. And she would get hypoxia regularly, which does happen. And after a while, you start to run off of a hypoxic drive. You can tell when the CO2 buildup. You can tell when there was CO2 buildup, or I'm guessing whenever it starts to get a little high, because you start to get into an altered state. So altered mental status happens. That's very true. Very true. Good story. Good story. People, I like when people kind of add more of the practical piece to it, or life experience piece to our training, because you're going to learn more from experiences than you're going to learn from this book, or you're going to learn from hearing me yap. So getting to see these experiences and being able to align those whenever you come across another patient, it's what we call recognition prime decision making. When we start making decisions for our patients, I implore you to look up Gordon Graham and recognition prime decision making, RPDM. Yep, absolutely. Altered state was similar to being very intoxicated and zero memory. That's very true. Because the brain is hungry. And the brain gets hangry, and that's what it acts like. It gets a little off. When I'm writing something in. There's a very good YouTube YouTube video Gordon Graham gives about RPDM when we start talking about that. But yes, also if you want to look up lung sounds on YouTube, it does have some pretty good lung sounds on there as well. Remember what we talked about before? When you're auscultating, you should be auscultating family members and everything right now, significant others, everything right now. You should be auscultating. Listen to the lungs, right? Apex, apex, base, base for right now. And then you can get further into it where you're listening for each lobe, and then going on the back, listening for each lobe. So do that. Know what normal sounds like before you start to pick up on what abnormal sounds like, because then you'll be able to listen and you'll be like, that doesn't sound normal, and then you'll start to be able to kind of narrow it down a little bit easier. All right, hay fever or allergic rhinitis. So it causes cold-like symptoms, including a runny nose, sneezing, congestion, and sinus pressure. So the symptoms are caused by an allergic reaction, usually to outdoor or airborne allergens, called hay fever for a reason, right? So anaphylactic reactions, severe allergic reaction characterized by severe airway swelling and dilation of the blood vessels all over the body. That's what that is. So it can be associated with widespread hives, itching, signs of shock, and signs of signs and symptoms similar to asthma also. All right, spontaneous pneumothorax. Spontaneous, sudden, right? Pneumo, air, thorax, in the chest cavity. So pneumothorax is the partial or total accumulation of air in the pleural space. Air, pneumo. It's often caused by trauma, but it may also be caused by medical conditions, like when we talk about spontaneous pneumothorax. So a lot of times when people cough really hard or some other, you can get it from infections and things like that. But somebody's really sick, they cough really hard, they can actually cause a spontaneous or a simple pneumothorax. A lot of times it happens in our taller patients. And it's usually associated with a pretty fair amount of chest pain. All right, so carrying on with spontaneous pneumothorax. So a vacuum-like pressure in the pleural space keeps the lungs inflated, right? So when the surface of the lung is disrupted, air then escapes into the pleural cavity, and the negative vacuum pressure is then lost at that point. So spontaneous pneumothorax occurs in patients with certain types of chronic lung infections or in young people born with weak areas of the lung. All right, so a patient with spontaneous pneumothorax becomes very, very dyspneic, and they might complain of pleuritic chest pain. All right, so breath sounds for the side that's having the spontaneous pneumothorax are going to be absent, or they're going to be decreased on the affected side. Okay. So it also has the potential to evolve into a life-threatening pneumothorax or tension pneumothorax, which means it starts to collapse over so much that now it creates tension on the heart, and it starts to push on this lung, and that's no good. When it starts to push on the heart, it's gonna squeeze the heart, and it's gonna cause it to not be able to pump effectively. Okay, invariably, it could cause what's called a cardiac tamponade. Some things you'll see with that is your JVD because of the backup, so jugular vein distension. But what you'll also see in later signs of it is going to be tracheal deviation. So here's the trachea here. So it's going to curve towards the good lung. So it'll be like this. It'll start curving towards the good lung. So you'll look, you'll see that curve in the trachea where it's aiming towards the good lung, and the neck's right here. And it's not going to be good. All right, moving on. Pleural effusion. So pleural effusion is going to be a collection of fluid outside of the lung. So it compresses the lung and it causes dyspnea. It can be caused by an irritation. It can be caused by an infection. It can also be caused by congestive heart failure, or as it can be caused by cancer as well. So the breath sounds are going to be decreased over the area where the effusion is present. All right, so patients feel better if they're sitting upright. So position of comfort for those patients. Most of these patients can be position of comfort. All right, obstruction of the airway. So obstruction of the airway. So a patient with dyspnea may have a mechanical disruption or obstruction, obstruction. In semi-conscious and unconscious patients, the obstruction may be the result of aspirations of things like vomitus or a foreign object. It can also be improper positioning of the head, and it causes the tongue to block the airway. So if the patient was eating just before the onset of dyspnea, always consider the possibility of a foreign body of obstruction. So there's some figures there that show obstruction of the airway by a foreign body. All right, moving on. Pulmonary embolism, PE, pulmonary embolism. So an embolus is anything in the circulatory system that moves from its point of origin to a distant site and lodges in there. Okay. So obstructing, what it does is it obstructs subsequent blood flow to that area or in that area. So circulation can be cut off completely. It can also be cut off partially at that point. Emboli, which is the small fragments. So emboli can be fragments of blood clots in an artery or a vein that break off and travel through the bloodstream or foreign bodies, such as a bubble of air, an emboli. So a pulmonary embolism is a blood clot that circulates through the venous system and the right side of the heart, and it lodges in the pulmonary artery, okay, which can then cause what? What we were alluding to a while ago, right-sided heart failure. A lot of times those patients will have the following symptoms. So signs and symptoms of this are going to be dyspnea, tachycardia, tachypnea, which is fast breathing, right? Varying degrees of hypoxia, cyanosis, acute chest pain, hemoptysis, so blood, right? Blood issues. You got also in like coming up can be an issue. Pink frothy sputum, or that sputum can come up. So with a large enough embolus, complete obstruction to the output of blood from the right side of the heart can result in sudden death. A lot of times these patients as well, they'll be panicked. They know something's wrong, and they will tell you that they got this impending sense of doom. They feel like they're going to die. Listen to those patients, and then take all of these together, and pay attention. So difficulty breathing, fast heart rate, fast breathing, pending sense of doom, cyanosis, hypoxia, acute chest pain. You get all of those, man, your brain should be hitting on all cylinders at that point, that this is an issue. We need to get them somewhere fast. I need ALS as quickly as possible. Boom, 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 boom. Because just as fast as it starts, it can kill you. No. So since it's in the lung, it's already in. That's something that's the part of the issue, that it's not going to be effective for that. Those people need cold steel. So you're going to have to give those people diesel or avgas. All right, hyperventilation. So it's going to be treated just like you would. You're going to have to, these patients, you're going to have to give O2, and it's going to have to be treated with ALS. They're going to need a paramedic there. because they're going to have to be intubated and everything else. It's treated by getting them to the hospital. Surgery. That's what's ultimately going to treat them. All right, so defined as overbreathe, so hyperventilation. Sorry, I got. Yep. So going back to the PE, yeah, that O2 is going to be about the only thing. And if they go out, then you got to run back to your primary, right? Run back to your primary and go through your ABCs and fix all of that. But the only thing that we can really give them is non-breather mask, crank that thing all the way up, and try to keep their SpO2 level above 94%, right? So that's why it's sometimes in your position, you can only do what you can do within your scope. That's kind of what pushes some people to be able to do more. So some people will go to paramedic school or be nurses or anything else because there'll be that one scene that they just felt absolutely helpless on. Speaking from experience, and they'll want to do more. All right, so hyperventilation. So defined as overbreathing to the point that the level of arterial carbon dioxide falls below normal. So this may be an indicator of a life-threatening illness, okay, such as the one we just went over. So the body may be trying to compensate for what's called acidosis. So acidosis is going to be the buildup of excess acid in the blood or in the body tissues. Okay. If you remember from earlier on, we talked about some of our body systems. We talked about aerobic and anaerobic. All right. So hyperventilation. So hyperventilation, it can result in alkalosis. Alkalosis. This can cause symptoms of hyperventilation syndrome or a panic attack. Hyperventilation syndrome, panic attack. So some of what this causes is anxiety, dizziness, numbness, tingling in the hands and feet because you're not breathing adequately, so low perfusion. Painful spasms in the hands or feet. We call those carpopedal spasms. So the decision whether hyperventilation is being caused by a life-threatening illness or a panic attack should not be made outside of the hospital. Get them some yonder. All right, environmental industrial exposure. So things like pesticides, cleaning solutions, chemicals, chlorine, and other gases can be accidentally released at industrial sites, and it can be inhaled by employees. So some other things too are like your carbon monoxide poisoning. Carbon monoxide is going to be an odorless and highly poisonous gas. A lot of times that happens whenever during storms. I'll talk about power outages. People use generators and they have the generator too close or the wind is blowing back towards the building. They got windows open, it gets in the house, and then everybody wakes up feeling very sick, or people don't wake up at all. All right. All right. So carbon monoxide poisoning is going to be the leading cause of accidental poisoning deaths in the United States. So carbon monoxide is so mostly like we talked about the fuel burning household appliances, and it's also present in smoke. So heavy smoke. So people who have carbon monoxide poisoning complain of flu-like symptoms and even dyspnea. Okay. Don't put yourself at risk for that. Pull them outside. If you come into a house and all of them are having the same symptoms, maybe they got redness, they're hot, red looking. Always take that into consideration. Flu-like symptoms, get them out of the house. So get them out of the house, give them high flow oxygen via non-rebreather mask. That's going to be the best treatment for your conscious patients. If they're unconscious, give them the BVM, 100% O2. You got to hook that BVM up to oxygen to get 100% O2. Yes, I have had to show people that. All right. So let's do a quick patient assessment. This is the guided patient assessment here. We'll do our own patient assessment here in a little while. All right, so patient assessment, scene size up. You're going to use your standard precautions and use PPE. You're going to consider the possibility of an infectious disease or toxic substance. If there are multiple people with dyspnea, consider the possibility of an airborne hazardous material release. Okay, so at that point, you may want to back out, get them to a safe area, get them out of there, get them off the X. So if the mechanism of injury or the nature of illness is in question, you may want to ask why 911 was activated. Hey, what had you or what made you call us today? What was it that made you call us today? Okay. So by questioning the patient, the family, and or bystanders, you should be able to determine the NOI for these patients. All right, your primary assessment. So in your primary assessment, you're going to identify any immediate life threats. If there are life threats out there, you're going to do what? Fix them, right? We're going to fix them. So if there's immediate life threats, fix them up. All right, then we're going to form an overall general impression of the patient's level of distress, sick or not sick, right? And we're going to note the age and the position of the patient. 54-year-old male lying supine in the ditch. 55-year-old female sitting up in the Fowler's position or sitting upright. So on and so forth. We'll use the AVPU scale, alert, verbal, painful, and unconscious, to check for responsiveness. Then we'll ask the patient about his or her chief complaint. Up next, we're going to assess the ABCs. We're going to make sure that the airway is patent and adequate. ABCs, airway, patent and adequate. And then we'll evaluate whether the patient's breathing is adequate from there. All right, assessing breath sounds. So you'll assess breath sounds. You'll check breath sounds on the right and the left sides of the chest. You see apex, apex, base, base on the left. And then we're looking for abnormal sounds that includes wheezing, rales, bronchi, stridor. And there's where you look at it in the back. And each one of these, you want to ask deep breath in, deep breath out. So I say deep breath in. All right, let it out. And a lot of times I'll either do it in, pursed lips out. With the pursed lips, then you're going to hear that air leaving the lungs all throughout. And if there's an issue, you'll be able to hear it pretty loud. All right, assessing circulation. So we're going to assess the pulse rate, rhythm, and quality. Rate, fast or slow. Rhythm, regular, irregular. Quality, bounding, weak, thready. We'll evaluate for shock and bleeding. So if we see any heavy bleeding, we're going to stop it, right? And shock, we're going to make sure we're covered up. Make sure that we treat for that shock. We're going to assess the perfusion by evaluating skin color, temperature, and condition. From there, we're going to make that transport decision. See how easy that is? Your 15 minutes is up right after this slide. So make transport decision, address the life threat if you need to, and then proceed with rapid transport. Get them some Yonder, right? Give them some diesel. All right, from there, we're going to evaluate the history, or we're going to do history taking. We're going to investigate the patient's chief complaint. What was the chief complaint? And then we're going to determine what the patient has done for the breathing problem. So with patients in respiratory distress, a sample history can be collected from bystanders or family if they're present, because we're trying not to stress out our patient, right? The OPQRST assessment can be used to assess the pain and gather information about the breathing problem. Also, the PACE assessment, PACE, it's a new one to put in your pocket. Write this down. So the PACE assessment is an alternative assessment for a complaint of shortness of breath or difficulty breathing. So you're going to ask about the progression. How did this progress, or how did this build up to this? Is there any associated chest pain with the difficulty breathing? Have you had any sputum or any spittle that's coming up? And looking at talking tiredness, so they sound like, or they look like talking tiredness. Exercise tolerance, can they tolerate exercise very well? Do they get tired when they talk? Can they exercise? All right. Then we'll move on to our secondary assessment after we have all the answers in the world that we need. So our secondary assessment, it only proceed with the secondary assessment if their life threats have been addressed and treated. So if life threats have been addressed and treated, we can move on to our secondary assessment. We'll use monitoring devices if you have them also. Secondary assessment of COPD versus congestive heart failure. All right, so patients with COPD are usually older than 50 years of age, often have a history of lung problems, are almost always long-term active or former cigarette smokers. They complain of tightness in the chest and constant fatigue. So the chest may have a barrel-like appearance because they've had this issue for so long. Now they have this barrel-like appearance. Barrel-chested. So often they use accessory muscle use to breathe. So you'll see the stomach going in and out. You'll see the retractions and all that good stuff. They exhibit abnormal breath sounds a lot. Often they exhale through their pursed lips. So pursed lips when they're breathing. Digital clubbing. So their fingernails and fingers at their tips of their fingers will be really wide, look like clubs. So it'll be clubbing. So all that is, it's an abnormal enlargement of the ends of the fingers. You will see it. You will see it. You work it out long enough. It's very recognizable. All right, reassessment. So you'll repeat the primary assessment. You'll determine if there's been any changes in that patient's condition. And then you'll confirm the adequacy of interventions and patient status. Interventions for respiratory problems can include things like providing oxygen by a non-rebreather mask at 15 liters a minute. That's high flow. That's high flow oxygen, right? 15 liters a minute. Whenever I give 10 to 12, it's just I'm titrating it down. That's a good level. 15 liters a minute is high flow. Whenever you're doing your EMT stuff, say 50. If you put a non-rebreather on, go ahead and say 15 liters a minute if you want to. So providing positive pressure ventilations using a bag valve mask device, pocket mask, or a flow restricted oxygen powered device may need to be used for some of these patients. Using airway management techniques such as oropharyngeal airway, oropharyngeal, or a nasopharyngeal airway, suctioning airway positioning may need to be used. May need to provide non-invasive ventilator support, such as CPAP. So positioning the patient in the high Fowler position or position of choice, whatever their choice is. So assisting the patient with respiratory medications, if they have any, may help out as well. So if they have any type of nebulizer or anything like that, you may want to assist with that. So communicate all relevant information to the staff of the receiving hospital after that. Let them know what's going on, and you'll be a winner chicken dinner. All right, the emergency medical care for these patients. So management of the respiratory distress, you're looking at administer of supplemental oxygen immediately, which is like your high flow O2, 15 liters a minute. You administer ventilatory support if the patient's mental status is declining. All right, if they're in moderate or severe respiratory distress or in the depth of respiration, if the depth of respiration is inadequate, you may need to look at that supplemental oxygen, look at getting a little higher on the echelon of ventilation. So you may have to manually ventilate this person, or sometimes you may have to provide CPAP to this person as well. So you want to monitor the patient's respiratory status while you're doing this and provide emotional support, because they can't breathe, so they're going to be amped up. Some of your patients may have a meter dose inhaler or MDI or a small volume nebulizer. So if they have that, you can assist with that. Consult your med control and make sure the medication is indicated for that. So consult your med control, tell them what you got, what you plan to do. They'll say, okay, or nope. And then you'll do what you need to do with that. All right. So also ensure that there are no contraindications to the patient's condition. So most respiratory inhalation medications that are used relax the muscles that surround the air passages in the lungs, leading to dilation of the airways. So some common side effects of inhalers are going to be like your increased pulse rate, nervousness, and muscle tremors. So medication from the inhaler is delivered through the respiratory tract to the lungs. If you want to know more about that, your skill drill 16-1 can be used to help for a patient to help them self-administer medication from an MDI. So if you want to help a patient, self-administer a medication from a small volume nebulizer, your skill drill 16-2 can also show you that. All right. Some more treatment. So treatment specific conditions. So upper or lower airway infection. You want to administer humidified oxygen if you have it available. Do not attempt to suction the airway or place an oropharyngeal airway in a patient with suspected epiglottitis. Remember the drooling. The drooling, tripod positioning, epiglottitis, no suctioning, right? You want to make sure to put them in a position of comfort and then transport those patients promptly. All right, moving on to acute pulmonary edema. You want to provide 100% oxygen, suction if it's necessary, position of comfort. You want to provide CPAP if it's indicated and allowed by protocol, and then you want to transport promptly. Your COPD patients, you want to assist with a prescribed inhaler. You want to watch for side effects due to overuse. So every 5 minutes, right? You want to watch that. You want to also watch if they overuse their inhaler. You want to pay attention to that. You also want to make sure they're in a position of comfort, and then you want to make sure that you transport promptly. For your asthma patients, so this is going to cover asthma, hay fever, anaphylaxis. So your asthma, be prepared for suction. Assist the asthma patient with prescribed inhaler if they have one, and then provide aggressive airway management and oxygen. So managing their airway, meaning if you got to provide ventilator or something like that, then you need to do so pretty quickly because it's squeezing off. They're going to be in a panic, and then prompt transport for that. Hay fever. Hay fever is unlikely to need emergency treatment. So, but you'll manage the airway. You'll give oxygen according to the level of distress there. No. So is supplemental O2 for COPD always a no? No, it is not. So you can still give them oxygen, and it takes a longer time for that hypoxic drive to kick in. If they want oxygen, oxygen may make them feel better. Give them oxygen. Like I say, if you plan on having an extended transport, like a long transport, then you may want to consider pulling them off and on it or what have you. But other than that, giving them O2 when it's needed, then do that. So hay fever, you want to manage the airway and give oxygen according to their level of distress. Moving on to anaphylaxis, you want to remove the offending agent. So if you need to brush off any chemicals, if you need to brush that stinger off or what have you, always make sure, though, that you provide aggressive airway support for those patients and airway management. Oxygen, and make sure you promptly transport those patients. So you can also administer epinephrine if it's allowed by your local protocol. If they have their own epinephrine, you can help them administer that. But if you are allowed to give epinephrine for your local protocol, do so. Make sure to get a hold of your online medical direction or offer online medical direction, one of the two, making sure that it's okay, or make the call. All right, spontaneous pneumothorax, provide supplemental oxygen, transport promptly, monitor carefully. We can't do chest needles here, or chest tubes, so that's what you're going to do. Pleural effusion, fluid removal must be done at the hospital. Gots to be done at the hospital. So what you're going to do is you're going to provide oxygen and transport them promptly. Notice all of them is transport. I haven't seen one yet that says transport in a slow manner. All right, obstruction of the airway. So partial obstruction of the airway provides supplemental oxygen and support. Complete obstruction of the airway, you want to clear the obstruction, administer oxygen if you can. No blind finger sweeps, right? And transport rapidly to the emergency department if you can clear it. All right, PE, or pulmonary embolism. Supplemental oxygen is mandatory. Position of comfort, if hemoptysis is present, clear the airway immediately. Suction that. So bloody sputum. And transport promptly. Hyperventilation. You want to complete a primary assessment and then gather the history if you can. Do not have the patient breathe into a paper bag. That's just rebreathing, and it's not good. All you're doing is rebreathing your carbon dioxide that you're breathing out, and that's not good. So reassure the patient and provide supplemental oxygen, and then transport promptly. All right, environmental or industrial exposure. You want to ensure your patients are decontaminated. You want to treat with oxygen and also adjuncts, and then suction based on whatever presentation that you're getting. Your patient presentation, not a presentation like some doofus up here teaching a class. All right, foreign body aspiration. So perform the appropriate airway clearing technique specific to that age or that patient's age. You want to provide oxygen and transport for that patient. Tracheostomy dysfunction. So position of comfort. You want to provide suctioning to clear the obstruction, and then place the obstruction, or I'm sorry, stupid. Once the obstruction is clear, you want to oxygenate the patient. You can do that through the stoma. All right, so for children, asthma for children, you can provide blow-by oxygen by holding the mask in front of the child's face. Just hold it in front of the child's face. You can use an MDI as you would with older patients. Sometimes they have that device that attaches the end of it that will hold it in there, and so it kind of lets them control the breathing into it. Right? You put it over on the mask. But you can use the MDIs the same way as you would your older patients. So as with any chronic disease, asthma may be a life-threatening in an older person. It can actually cause a lot of issues. Cystic fibrosis. So it's a genetic disorder that affects the lungs and digestive system. It's predisposed in children, or it predisposes children to repeated lung infections also. The symptoms are going to range from sinus congestion to wheezing and asthma-like complaints. So for those patients, you want to make sure to suction and oxygenate as needed. All right, so what we're going to do is take a 10-minute break. Then we're going to come back and we're going to knock this out. No, knock it out. All right, so take a 10-minute break. Let me put this on up. All right, so starting out, who wants to be the first victim? Who's it going to be? Take any volunteers? Y'all are going to make me choose somebody.
I'll try it.
All right.
Oh,
Devontae, you got this, man. You got it. All right, here we go. So, let me get my stuff going on here. Where did I put it? Right there. Right. Left side of the screen. Let's do this for the right side of the screen. Perfect. All right. I built a bunch of scenarios the other day, or a few scenarios the other day. Should go pretty well in line with the way that we've been doing this.
okay.
All right, so have a. Do I have the right one? Yes. All right, so I have a 45-year-old male. Oh, let's do this the better way. All right, so let's do this. Dispatch. All right, so dispatch pops up and says, "Brr. Yes, medic 51. I have a 45-year-old male complaining of difficulty breathing. He is on 123 Anywhere Street, and next that's going to be right off of 123, or cross with 123 Anywhere Avenue. Please let me know when you're en route." And that's going to be it. I would be a terrible dispatcher. All right. So what are we doing? So when you're on your way, what are you thinking about right now? Difficulty breathing. That's all you got.
I'm thinking about, well, I know that the scene's gonna be, well, in my head, I'm thinking that the scene's gonna be safe, so kind of got my scene size up in my head to be decent, maybe like a patient somewhere in
Yeah.
a
All
slumped
right. So
over somewhere.
what are you gonna do first? So you're pulling up on scene. What are you gonna do? You got to verbalize it.
Um, I guess like I, this the PPEs. I need to put my gloves and maybe a mask on for
Yep.
this situation.
So BSI is my scene safe, body substance isolation. So BSI is my scene safe. That's all you got to say. So whenever you see that, what will you do first? You just come in the room whenever you do your assessment. BSI is my sign safe, or is my scene safe, and then that instructor is gonna go yep. And then whenever you're in the real world, you're not gonna walk in and go BSI is my scene safe. You're gonna be looking at that, and you're gonna put on your stuff.
Okay, gotcha.
Yep.
And then after that, I would kind of like move over. Well, I guess we're at the scene. Yeah.
Yep. All right. So scene safe. All right, so you're putting on your gloves and your safety glasses. Let's say this picture doesn't represent where we're at. It's just a picture. So let's say, what are you gonna do next? You're gonna come up and
Um,
you got all your clues right here. Everything you
yeah.
need.
Nature of illness. Like try to talk to the patient. Uh, find out the nature of illness or mechanism of illness.
So
He probably
right
won't
now, all
know.
we
He's
know
just gonna
is
say,
difficulty breathing,
yeah,
right?
exactly. Another
So
number of patients would be one, hopefully, in this situation.
yep. So you
And
have
do I
one
need
patient.
additional resources? I probably wouldn't, being that I was there. And then do they
That's very confident.
hopefully I wouldn't need any additional resources, being that the
Okay.
patient's talking to me, directly and stuff like that.
Okay.
C-spine, I don't think that like any like spinal injuries are occurring right now with this. But I could make sure that the patient is able to be like stabilized.
So the patient, when you determine your scene situation, just ask, "Hey, is my scene safe?" And I'll say, "Yeah." I'll say, "So you're inside the patient's living room, and there's no immediate hazards at this point."
Okay.
That's awesome. So your nature of illness, like you said, difficulty breathing. There is one patient. No additional units needed at this time because it seems like everything's going okay. Uh, the C-spine's not necessary due to the nature of illness that we have. Right now, you're in what phase of your assessment?
Um,
You just
the
finished the scene size up. Now you're in what phase?
in the primary, I guess. I don't know.
Awesome. No, you do know. You're on it.
Oh,
All right.
okay.
All right. So what you see is you see a 45-year-old male sitting upright, appearing anxious with audible wheezing. Right. So so first things
The
first, you're
wheezing.
doing what? Your general impression. And
Yeah.
what do you think? Oh, I bet it would help if I pop that up there.
I see him wheezing, and maybe he will have like his hands on his chest.
So he's wheezing right now. All right. So your general impression of this patient is what? Sick or not
Um,
sick?
sick, sick.
Yep, he is sick.
Need
All
tap.
right. So when you walk up, he looks straight at you. He looks straight at you, and he's following you into the room, right?
So he's conscious, and he's
Yep. So
conscious.
he's alert, right?
No, well, I guess would that be a life
So
threat?
he's so no. So right now you're walking up to him and he's looking at you. He's just
Okay.
looking at you
Yeah.
and getting ready for you to speak. So right now he's actively noticing where you're at, so he's alert. We know his LOC is alert. All right.
And then I would do a assess airway. His airway and breathing is I guess I would give like a number towards that, or
So we would take and like you would determine the chief complaint from there. So determine the chief complaint. We know that the chief complaint is difficulty breathing. He's wheezing, so he's probably got a history of what?
I don't know, heart
What?
problem.
Nope. Remember wheezing?
Wheezing.
A lot of times comes with what? What disease process?
Man, hold on. Sorry, I just had this one.
Sorry. A lot of times your younger patients have it. Remember it said 5 to 17 years old?
Is it I don't know. Someone says asthma.
Yep. Asthma. Yep. So possible asthma. Okay. Possibly a history of asthma. All right. So you see that you're doing airway. What are we looking for in the airway?
Any obstructions or things blocking passage.
All right. So you hear audible wheezing and you see accessory muscle use.
So that means like the muscles are flailing, like.
Yeah. So his breathing is labored at this time. So if he's breathing is labored, he's got accessory muscle use. What should we automatically do for this patient that could help him out?
Oxygen.
There you go. All right. So how do you want to give that oxygen? Oxygen via what?
Nasal.
Let's
Mouth.
go, since he's got labored breathing. Let's go a little bit. Let's
the
be
mask.
aggressive. Yep. So non-rebreather mask, and we're gonna set it to what?
Wasn't it 12 to 15?
Yep. So what I would say is just set it to 15.
Yeah.
So yep, set it to 15. Give them high O2. So administering oxygen via non-rebreather at 15 liters a minute, LPM, 15 liters per minute. All right. So from there, that takes care of your airway and breathing, right? So next, we're gonna look at we're gonna assess the what?
Circulation of all his circulation by like pulse and blood pressure.
Oh, so let's look right here. That's vitals.
Okay.
Remember when we're in the primary is just quick. So we're assessing for
major bleeding and checking his pulse and assess the skin checking. I forget what that was called, like the little to see if the blood comes back to his skin.
Yep. So skin color, temperature, and condition, right? That's right. So there's no active bleeding.
Okay.
He has a rapid and strong pulse, and then his skin is pale and cool.
Okay, so he has circulation.
Yep, he does have circulation. All right, we're moving on.
And then yes, I would transport him. I would recommend just due to the way he's breathing, and just to get an evaluation.
Yep, he's a high priority, and he needs to be transported promptly, right? Yes. Everything we saw tonight was transported promptly, right? So he's a high priority, and transport him promptly. He's on O2 right now. So we just completed that within 15 minutes. Awesome job. So you've passed a big hurdle that hangs people up in the patient assessment portion of the NREMT psychomotor exam. It also hangs people up all the time on scenes. So you got that down. Good job. So we're all right, moving on. Huh?
I said I learned a lot as well.
Awesome. All right, so moving on. Up next, we're in what phase? So we went from primary survey and resuscitation to now we're in what?
History taking.
History taking. All right. So what do we do during history taking?
You want to find out any past things to do with the illness that's at hand.
Okay. And how do we do that? What specifically how do we do that? What do we use?
I don't know what the acronym stands for. Again,
Right.
OPQRST.
Yep. So who wants to help him out? OPQRST, if y'all type it in. Okay. O is onset.
Okay.
P is what? Provocation. Okay. Q is what? Quality. There you go. R is radiation. All right. S is what? Severity. Awesome. And
Okay.
T is what?
Time.
Time. Awesome. All right. So we got onset, provocation, quality, radiation, severity, and time. All right. So how would you ask a question for onset? So if I'm the patient, what would you ask me to get the onset answer?
A sample.
Nope. I'm talking about for OPQRST. It's got its own questions,
sorry.
remember? Yep. No, it's all right. So,
like are you allergic to anything or?
hold on, I'm asking onset questions. So ask something like, about how long ago did this start? Like, when was the
Okay,
onset?
I see.
Yep. About how long ago did this start? And I would say about an hour ago. Right. And then so now we're in quality. So what would you ask about quality? How would you ask that?
I don't know. I need some help on this one.
Remember, quality, we're asking a description. So can you give me a description of what's going on? And what in your based on what you have to say, what is a description of what's going on with you? And so I would say it feels like I can't get enough air.
Okay. And then I go from there, like, is it
All right.
like
So
how you feeling? The
yep.
severity?
So from there, oh, I forgot P. Sorry about that, ladies and gents.
Okay.
So does anything make it better or worse? That's what you would ask for provocation. So for P, does anything make it better or worse? And I would have answered, I ran out of my inhaler. So in my
That's a
inhaler
good
usually
thing.
makes it better, but I ran out of it. So it's not
So I
making it
would
any better.
think about trying to administer an inhaler. That's like I'm thinking of that while
If you're
doing this
able
question.
to, if you're
Yeah.
able to, if it's a possibility or possibly a nebulizer or something like that, that's a
Right.
possibility. So radiation would be a no. Time is it's getting worse. It's just getting worse.
Okay.
So one thing that I do ask for clarifying questions to clarify OPQRST is, do you have any chest pain or dizziness? I always ask that. Do you have any chest pain or dizziness? And this gentleman would say no. All right. So now we're in sample history. So sample history, signs and symptoms. We've already said it. So you would say, hey, what's going? So you already said signs and symptoms, which was it's difficulty breathing. I'm having difficulty breathing. It's hard for me to, or I can't get enough air in, and I don't have chest pain, so we're not worried about that. So allergies would be next. Do you have any allergies? No. And then do you take any medications? And which I just said I took an inhaler, right?
Yeah.
All right. So
P.
next is P. What does P stand for?
I'm still working on all these analogies and stuff.
It's okay. Hey, have you printed off your skill sheet yet from Canvas?
I haven't printed it off, but I've been using it, but I'm trying not to use it right now.
I understand. I understand. Just use it as
But
some guidance. So,
yeah.
so P is going to be past pertinent history.
There we go.
Past pertinent history.
History
And in that case, I would say yes, but I have my past pertinent history is going to be asthma. I have asthma. Okay.
and the person,
But it's usually I do have asthma, but it's usually not this severe. All right. Then medications. Thanks. I forgot medications. So medications. Oh no, I didn't. I said inhaler. Last oral intake is next. So how would you ask last oral intake? What do you ask? What question do you ask for that?
what was the last meal you ate?
Yeah.
Or
What was the last thing you had to eat or drink?
eat or drink? Yeah, because fluids as well.
Yep. So I say dinner about 2 hours ago. I had a water with it. All right. And then E would be what?
Um, what was leading up to it?
Yep. So the events leading to present illness. I would say the events were I ran out of my inhaler medication, and at that time, it got worse. My problems got worse. All right. So you finished up your history. Did you write that down?
Yeah, I have it all
Yep.
on the side.
Awesome. Because remember, at the end, you'll have to give a patient report. All right. So now we're moving on from our history taking to what's next.
Sorry, I'm still writing.
All right.
Going to from our history taking to, I guess we need to be getting him to our second. We need to be transporting him and doing our secondary assessment.
Yep. So we're already transporting. We're heading down the road right now. So we're doing our secondary assessment. All right. So would you make this a detailed or a focused assessment?
I would focus on the chest area, upper chest area.
Okay. All right. So you could assess the chest, right? You could assess those areas, assess those body systems. So mostly we're assessing.
Cardi.
Nope. So we're gonna assess what system. So
The
pulmonary,
heart.
right? So
Oh,
pulmonary. So lungs. We're dealing with respiratory today, so lungs. So we're gonna assess the pulmonary system. All right, because if we assess cardiac, then you would see that you're tachycardic because we talked about that. Tachycardic with strong peripheral pulses.
yeah.
We talked about that. Neurologic, we already said was alert and oriented. We'll say alert and oriented times 4. Pupils, pupils are going to be equal and reactive to light. Pearl, your integumentary system or your skin, there's no abnormalities. So you can go down the line if you want. Reproductive, it's not applicable to this, right?
Right.
Pulmonary is going to be wheezing in all lung fields. So if we're finding wheezing in all lung fields, what are we doing? What are we having to do to that patient? So if we're checking pulmonary, how do we specifically check that?
I'm sorry. Could you ask that question one more time?
So if we're checking pulmonary, how do
Yes.
we assess that?
Yeah, checking the 4 points for access in the front and back.
Yep. So we're gonna check. We're gonna auscultate. We're gonna
Auscultate.
auscultate. Yep. So we'll auscultate.
Asking the patient to breathe in and out. Seeing the sounds, comparing the sounds of each lung.
Yep. We're gonna listen to lung sounds. So upon listening to lung sounds, there's gonna be wheezing in all fields, in all lung fields for this patient. Okay. And then if you go through it all, then musculoskeletal, there's not going to be any deformities or injuries that were noted. GI or GU, there's no complaints for GI GU. And then psychological or social, I'm anxious. Okay. All right, so we moved on from secondary assessment now into vital signs. So we moved from our focused assessment into vital signs. What vital signs would you like to get?
I'll start off with the blood pressure.
140/90.
All right. And the pulse.
So your initial pulse is 110.
And my respiratory rate, I guess.
So
How many times? The quality.
respiratory rate and quality is 26 and wheezing. Anything else?
And I would probably check, I don't know, do we have to check the eyes as well? Stuff like
Not
that?
necessarily. We did. It was Pearl. But you may want to take an SpO2, right?
Right. Yeah, I would.
Pulse ox. So you
yeah,
want
pulse
to
ox.
check your pulse oximetry. So pulse ox initially it was room air was on room air was 92%, but you got him on O2. So your
It
pulse
should
ox should be.
be 90, 94 higher.
We want to make sure it's 94 or higher. That's right. All right.
Temperature.
So what is your, so I would challenge to say we don't have temperature checkers in the ambulance for the most part. We don't have that. Now blood glucose, you could do that.
Do a quick prick.
Yeah, you could do that, but I would not. It's not specifying that.
Okay.
There, because it's a little invasive. And if it's for a respiratory, then I wouldn't get a blood glucose. If he was giving me signs and symptoms, altered mental status and all that, not the anxious, not counting anxious, but if he was doing something else that was aiming towards that, then I would possibly get a BGL, but I'm not going to get that for a patient that's not displaying any type of diabetic issues.
And he's
So,
mostly just anxious because he's scared in this situation,
yeah,
right?
he's anxious because he's scared. That's
Right.
right. That's right. So what do you think is going on with this patient? What is you're going to state your field impression of the patient. What do you think is going on?
I think that he is having a small, like maybe had a small asthma attack.
So let's call it an acute asthma attack. Okay?
Acute
An acute,
asthma attack.
yep, an acute asthma attack. That's what we'll call it. That's the proper term for it, right?
Mhm.
All right, so the interventions for this, you gave O2, but what else do you think you could give this patient? If it's in your protocol, what do you think would probably be good for this patient? He's out of inhaler. We don't really carry inhalers, but we do carry something else that you may be able to get passed through med direction.
Well, hold on, sorry. The breathing treatment, like
Yeah, a breathing treatment. So write it down. Breathing
nebulizer.
treatment.
Yeah.
Yep, nebulized bronchodilator.
Nebulized.
Yep, nebulized bronchodilator.
Thank you.
No problem. And then you put on there per protocol or per online or offline med direction. All right, depending on what you do. And then you're going to continue the oxygen and you're going to continue the transport. All right. So after you give them a nebulized bronchodilator, you want to do what? So after you give a treatment, you want to do what?
Make sure he covers for shock. Like make sure he doesn't go into shock. Stuff like
Okay.
that.
What else? So you just gave a treatment.
Oh yeah, and reassess.
Yep. So you want to reassess. That's right. So reassess. First off, how often do you think you'll reassess this acute asthmatic attack patient?
Every 5 minutes, I guess, because
Awesome.
it is it's still an asthma attack.
Yep. You're not guessing. You're doing good, doing fantastic. So with your patient here, you gave the bronchodilator. So your blood pressure is 130/80. Your pulse is 100 now. Your respirations are 20, which is less. There's less wheezing. Your SpO2 is now 95%. So you're good to go. You're getting better. There is
Right.
market improvement.
Yes.
All right. So up next, after your second set of vitals there, and after your interventions and second set of vitals, we're going to continue to do what? Every 5 minutes, you said?
Yes, every 5 minutes, reassess the patient to see if the treatment is going well and if we need to continue the treatment. In this
Yep.
case, I would say yes.
Awesome. Awesome. All right. So like you said, every 5 minutes. All right. So now you're at the hospital and it's time for you to meet Nurse Karen. So Nurse Karen's like, yeah, what you got? Let's hear it.
We have a 45-year-old male complaining of chest pains. Crap. And has a past history of asthma.
Mhm.
Was wheezing after checking for checking sounds of the lungs. I heard wheezing all around.
Okay.
There no injuries surrounding, like no surrounding bodily injuries other
Great.
than
Pertinent.
the
Pertinent
asthma.
negatives.
Yes.
Okay.
He's a little anxious, maybe like he has a little bit of anxiety right now due to the circumstances of the chest pains and
Okay.
the asthma rhythm. His blood pressure, my first set of vitals in were 140/90,
Okay.
110 rep, uh, and he was still wheezing with and sorry, 140/90,
Okay.
110 and 26. Sorry, I'm blanking out right now.
Nope. 26 breaths a minute. So
With
his initial vitals were 140 over uh
90.
his initial vitals that you took were 140 over 90. His initial heart rate was 110. He was 26 and wheezing for respiratory,
Respiratory.
and he was 92% on room air. We went ahead and gave intervention for this patient, which was what? What did you do for intervention? Just go ahead and give
Nebulizer.
all of them.
We gave him nebulizer, oxygen, regular oxygen, and we reassessed every 5 minutes to make sure our interventions were working.
Okay. And were they working? How do you know they were working? What were your
And my second go around, I see the decrease in his numbers.
okay?
His blood pressure was 130/80. His heart
Mhm.
rate uh decreased. I didn't know that. I didn't hear that one too well when you said it, so I'm just gonna say it decreased
His heart rate decreased to 100.
to 100, and his respirations decreased to 20, so he calmed down, and his wheezing wasn't as prominent as it was first go around.
Okay.
His SpO was 95, so it balanced out after treatment.
Cool. All right, great. Yep, 45-year-old male patient. Chief complaint was an acute asthma attack. Nature of illness was, or the nature of illness was the asthma attack. Sorry. No traumatic injuries in this patient. His respiratory distress was mainly due to what we're thinking is his asthma, his history of asthma. He ran out of his inhaler. Just stuff I mentioned in there. Um, his signs and symptoms, wheezing, anxiety, his vital signs when we first got there, like you said, when we first got there, His vital signs were 140/90. They were, and you give us all his bad vital signs. Like, so what we did is we went ahead and put him on O2 and did a nebulized bronchodilator. This resulted in a blood pressure of 130/80, pulse 100, respirations 20, and an SpO2 coming from 92 up to 95. And then you ask, do you need anything else? And they'll say, yeah, sign this and then leave.
Right.
So fantastic. Good job. All right. So awesome. It's good stuff. All right. So moving on. So done with the review, or we're done with the patient assessment. Let's push on to a review. All right. So the process in which oxygen and carbon dioxide are exchanged in the lungs, what do we call that? Ready? I'll tell y'all when to answer. All right, go for it. Answer. A. Good job. All right. Which of the following respiratory diseases causes obstruction of the lower airway? I'll tell y'all when to answer. Hold on. All right, go ahead and answer. All right, so we got some C. Obstruction of the lower airway. B. So asthma, lower airway. Asthma. Yep. So B is, so asthma is always lower airway. Remember, anything respiratory distress wise is always caused by, or is always an obstruction. Lower airway, I always think of asthma a lot of times, if that's one of the choices. All right. All right, which of the following diseases is potentially drug resistant and is thought to be transmitted by coughing? So hold your answers. Hold them. All right, go ahead. Okay, got a lot of A's, a lot of A's. A, tuberculosis. Good job. Fantastic. Good job. All right, all of the following are causes of acute dyspnea except, all right, hold your answers. Hold them. All right, answer away. Go for it. Okay, we got a C. Got a D. Got an A. Ooh, this one's a good one. Got a B. Got a B. All right, so acute. So now we're getting the good answers. Acute. So chronic and acute. So chronic means long time. Acute means right now, right? So which one of these, if you want to change yours, is causes of acute? So all of them are causes of acute except. So which one is the except? There we go. All right. So let's see. B, emphysema. So chronic meaning long time. Acute being short. All the rest of them were acute issues. But they ain't nothing cute about it. All right, bronchospasm is most often associated with, hold your answers, don't answer, do not answer. Bronchospasm, spasm. All right, go ahead, put it out there. 6. We got a 6 so far. they didn't put A, B, C, D. Okay. All right. Now, what is, okay, all right. All right. Got a lot of 6s, got some 5s. It's going to be 5A. It's going to be asthma. Going to be asthma. Because remember, bronchitis is inflammation. All right. And then asthma is going to be bronchospasm. It spasms and closes together or closes up. That's going to be asthma. All right. 5, 6, 7, 8. That's funny. All right. Awesome, awesome, awesome. Fantastic, everyone. All right. So in closing, does anybody have any questions for me about this chapter, about what we went over today? All right, if there are no questions for me about this chapter, then your class code is 1980. That's 1980. Yep. Don't forget to do your attendance forms. So 1980, what happened in 1980? So the Emergency Medical Treatment and Active Labor Act, EMTALA, so EMTALA. EMTALA is enacted in the United States. That's it's what it does. It's requiring hospitals to provide emergency medical care regardless of a patient's ability to pay. So the passage of EMTALA was a significant milestone in ensuring access to emergency medical care for all individuals, regardless of their financial situation. It made it illegal for hospitals to deny emergency treatment based on a patient's ability to pay. Okay, there are people that still think that if you can't pay, you can't go to the hospital. There are people that still think that. So what this does, it's emphasizing the principle that emergency medical care should be provided without delay or discrimination to anybody. All right, so that's going to be 1980, EMTALA in 1980. All right, so what's coming up due this weekend? This weekend on Saturday, August 12th. No, there is no self-study chapters in this particular module. So just chapter 1 was that. Self-study, self-test, all that good jazz. All right, so coming up due this Saturday, August 12th, 2023 at 11:59 p.m. is when it will close. Chapter 15, Medical Overview, which is what we went over. It's going to be in your Platinum ED, Chapter 15, Medical Overview, and Chapter 16, Respiratory Emergencies. All right, so both of those are in your Platinum ED. They close out. They're open right now. They close out August 12th, 2023 at 11:59. So don't turn late. All right, so what are we going to talk about next Tuesday? So next Tuesday, we're going to talk about cardiovascular emergencies, Chapter 17. So go ahead and read up on Chapter 17. So when we come in here on Tuesday, y'all are ready to knock it out. Y'all are ready to knock it on out. Other than that, that is all I have for tonight. And I'm going to go ahead and stop recording. Thank y'all very much for stopping by. If y'all want to jump out of here, feel free to jump out. After I stop recording, feel free to ask me any more questions that you need to ask. All right, so thank y'all very much. Y'all have a good night and a great weekend.